I'm Dr. Ronald Berkman. This video will deal with selected aspects of induction of labor. Upon completing the assigned reading material, viewing this video, and participating in the follow-up session, you should be able to discuss indications and contraindications of induction of labor, as well as cervical ripening, the methods used for inducing labor, as well as the methods used for cervical ripening, and factors which may increase the safety and success of induction of labor as well as cervical ripening, and the complications of induction of labor and cervical ripening. If we look at this chart, which looks at the rates of labor induction in the United States between 1990 and 2012, you can see, if you follow just the dotted line, that in 1990, basically about 10% of labors were conducted through induction. And this increased actually fairly dramatically over the next years to a rate of almost 20% in 2012, and certainly that rate has not reduced to any significant extent in the ensuing years since 2012. Now, the reason for the increase is not clear, but it's probably because of a widening of the reasons to induce a labor related to underlying fetal or maternal conditions. Some of the major indications for induction of labor are listed here. Certainly premature rupture of the membranes, particularly if it's rupture at 34 to 36 weeks and beyond. This is a reason for labor induction. Post-term pregnancy certainly is an important indication for inducing a labor. A variety of hypertensive disorders of pregnancy, including preeclampsia as well as chronic hypertension that cannot be readily managed, are also reasons for labor induction. Whole host of maternal conditions, including diabetes, renal disease, cardiopulmonary disease, also often lead to induction of labor. Fetal demise, particularly with a fetus that's 24 weeks and beyond, is a reason for labor induction. Chorioamnionitis is also another indication. Abruption, as long as there's not excessive bleeding that cannot be controlled, and fetal abnormalities relative to tolerance of the abruption, certainly that would be an indication for an induction. Cholestasis of pregnancy usually leads to induction around 37 weeks. Twin gestations certainly are frequently induced. Other fetal reasons include oligohydramnios, IUGR, isoimmunization, and it can include rarely a breech presentation. Elective induction now is increasingly common, particularly since the ARRIVE trial suggests that, again, induction at 39 to, say, just under 41 weeks may, in fact, have the best chance of success and the least morbidity. The contraindications for labor induction are listed here, and the first three on the left-hand column relate to the type of uterine incision that has occurred previously, and these incisions, again, would increase the risk of uterine rupture should a patient begin contracting in a spontaneous labor or induced labor. So these would include the prior classical incision, if there's a significant extension of a prior transverse uterine incision, or there's been a myomectomy that's gone into the endometrial cavity, particularly if the myomas that were removed were of substantial size. Other indications include active genital herpes, cord prolapse, placenta previa or vasa previa, a transverse lie, invasive cervical cancer, and certainly a Category 3 fetal heart rate tracing. It's important, regardless of what the indications are for induction, that a patient be carefully assessed. It's particularly important that if you're doing the induction for electively, say at 39 weeks, or for post-states, that you have a good basis for the dating of the pregnancy. It's important that you know what the fetal presentation is, and it's important also to know the estimated fetal weight. For example, if you're doing induction on a diabetic, you'd like to avoid, obviously, having to deliver a fetus that's, say, over 4,500 grams because of the risk of shoulder dystocia. Bishop score can be utilized to estimate the likelihood of successful induction. It's important to also review the fetal heart rate pattern to ensure that there's not an abnormality that's occurring, that the addition of ripening or oxytocin as a time of induction would make the pattern worse. And finally, you review the patient's history for any other potential issues that may lead to risk of complications during the labor induction. It's important in terms of the estimate of a term gestation that you use one of these three approaches. Certainly an ultrasound measurement done at less than 20 weeks, which supports a gestational age of at least 39 weeks, certainly is an effective way of doing this and is reasonably accurate. Or you should be able to show that fetal heart tones have been documented as present by Doppler ultrasound for at least 30 weeks. Or that it's been at least 36 weeks since there was a positive serum or urine HCG test. The Bishop scoring system certainly has been widely used since 1964 as a means of determining whether a cervix is ripe or favorable for induction. And it basically utilizes dilation of the cervix, position of the cervix, the occurrence of effacement, the station, cervical consistency, and assigned either 0 to 3 points for this. In many of the studies, a Bishop score greater than 6 suggested that the cervix was favorable, though some have used the cutoff of 8 as being perhaps more accurate. There's also others that have developed alternative approaches in terms of modifying the Bishop score. And this is a study done a number of years ago where 5,600 nulliparous women between roughly 37 and 42 weeks were evaluated. The inductions were elective or for postdates or for a condition that could be managed expectantly. And when they examined the use of the Bishop score and the various components of the Bishop score, they determined that cervical position and consistency were minimally predictive of successful vaginal delivery, and then they dropped it for the rest of their analysis. And they came up with a simplified score that included dilation, effacement, and station with a possible maximum score of 9. And keep in mind that the original Bishop score, if it was greater than 8, indicated that there was a probability of vaginal delivery after induction similar to that that would occur after spontaneous labor. So when they compared the two, it turned out that a simplified Bishop score greater than 5 compared to an original Bishop score greater than 8 had similar positive predictive values as shown here, and similar negative predictive values, so that some may in fact feel that using the simplified score, since it's less, shall we say, due to sort of subjective judgment as one determines whether cervix is anterior, posterior, soft or firm, may be a little more reliable. Now, there are multiple methods that can be used for labor induction. These are listed here. They include osmotic dilators, balloon catheters, particularly the Foley catheter, prostaglandins, membrane stripping, amniotomy, as well as oxytocin. Certainly, the balloon catheters and prostaglandins are probably most frequently utilized, at least in this country, for ripening of the cervix. Oxytocin is sort of the standard for the actual induction in most cases. Osmotic dilators are listed here. There's first the Laminaria japonica, which is a form of seaweed. It absorbs water, can stretch the cervix, and release prostaglandin. So it has two effects in terms of changing the consistency of the cervix that allow prostaglandin to work, and also some mechanical stretching. However, there's limited data on efficacy, and because of the size of many of these, multiple laminaria have to be inserted in most patients, particularly if they are near term. Lamisil, which is another form of osmotic dilator, decouples collagen cross-linkages, increases the cervix's sensitivity to prostaglandin E2 or Cervidil, and appears to be somewhat equivalent to Cervidil if they're used alone in induction time. Dilapan, another form of an osmotic dilator, does cause some mechanical stretching, but there's limited data on efficacy. The relative contraindications of all of these are low-lying placenta and ruptured membranes. Also, there are risks of retention of the device and potentially of infection, though GBS positivity is not an absolute contraindication if patients are being treated and there's no symptoms of, say, chorioamnionitis. Balloon catheters, such as the Foley, certainly are widely used for cervical ripening and to some extent for even labor induction. Certainly you can utilize a Foley and hopefully have a Foley catheter that can accept between 30 and 80 cc's of saline, as well as there are specialized double balloons available for this particular indication. There does not appear to be a difference in outcome when using a Foley or a specialized balloons in general, or if using a 60 or 80 cc balloon in either of these. However, if you're using a balloon that is 40 cc's or less, they appear to be less successful. Insertion is via ring forceps using a speculum or manually with insertion technique with your fingers, similarly to insert in an IUPC catheter. Generally, use is discontinued if it's expelled in labor or after 12 hours. Longer use, however, is not contraindicated. From the standpoint of efficacy, balloon catheters are similar to Cervidil for both duration of labor and the occurrence of cesarean delivery. However, they are less effective when you compare them to either oral or vaginal low-dose misoprostol. If you combine misoprostol and a balloon, there appears to be a shorter induction time when the balloon catheter is used by itself. And there seems to be modest improvement when the balloon use is combined with either oxytocin or Cervidil. When you look at balloon catheters by themselves, there's a lower risk of tachysystole with abnormal fetal heart rate changes when you compare them with the use of Cervidil or misoprostol. And when you look at the data related to whether extra amniotic saline being instilled at the time that the balloon is placed is beneficial or not, basically the results are conflicting. This shows a diagram of a Foley catheter balloon with extra amniotic saline being inserted. This one is a 30 cc balloon, and if you go by the data that's available, this would have probably a less chance of being helpful than, say, a balloon that you could dilate up to, say, 60 cc's. This is a picture of a double balloon, and you can see, if you look in the upper left-hand corner, you can see there the distal balloon is the balloon part that's inserted into the cervix and goes beyond the internal os, that then is blown up. And the second balloon is then blown up and again allows the catheter to stay in place for a longer period of time than perhaps the Foley. Next approach used for either ripening or induction are the prostaglandins, and the two prostaglandins that are available for this use include PGE1, which is misoprostol, or PGE2, which is Cervidil. And certainly the vaginal versions of these prostaglandins appear to be more effective than the balloon, oral misoprostol, or intracervical prostaglandin E2 in achieving ripening or delivery within 24 hours. So vaginal use appears to be more effective. There is tachysystole with or without fetal heart rate changes occurring in up to 5% of women with prostaglandin use for ripening or induction, and appears to be higher if oxytocin is used at the same time, with some data suggesting you can get up into the 10% or higher range. Prostaglandin E1 or misoprostol has in its product literature a contraindication to its use in prior cesarean delivery. This is not listed for Cervidil, but most would avoid prostaglandin in any of these patients who have the uterine scars of a prior cesarean delivery or an extension of a as I say, a myomectomy incision or things of this sort. This data is indicating how the misoprostol levels are when you compare oral versus vaginal administration. You can see that with oral administration you have the typical sort of curve where you get a sort of peak value and then a fairly rapid fall off. However, the vaginal administration, certainly peak value takes a longer period of time for it to occur. However, the levels remain elevated to a significant degree for a longer period of times, and this obviously may relate to why it is more effective than oral administration of misoprostol. Membrane stripping for cervical ripening or labor induction. This is probably confined to primarily patients who have a very ripe cervix, in a sense that their Bishop score is high and they're at terms, and certainly it appears to increase the likelihood of spontaneous labor within 48 hours and reduces the likelihood of induction being required by other methods when you have, again, a very favorable Bishop score in a term patient. However, based on a large Cochrane review, it appears that you still would have to do membrane stripping on 8 individuals to prevent the requirement for induction of labor in 1 individual. Now, the systematic review did not show an increased risk of premature rupture of membranes with this practice, but clearly it does have discomfort for the patient, and there is some risk of vaginal bleeding. And there is very little data on whether this adversely affects women being treated for group B streptococcal infection. Amniotic for cervical ripening or labor induction also is certainly utilized, and it usually is used in combination with oxytocin. And there are a number of papers that say it is appropriate for use if the cervix is favorable and the head is well applied to the cervix, though there is no comment on application to the cervix in the practice bulletin. Use can reduce the number of women undelivered at 24 hours, as I mentioned, if particularly used with oxytocin. If you use amniotomy alone as your approach to delivery, 16% are undelivered after 24 hours. However, if you combine it with oxytocin, a minor number of patients, 2%, are undelivered. Here again, there's no data on the risk of coronary amnionitis if used for women being treated for group B streptococcal infection. We now get into induction itself, and this is a table that outlines for you low dose and high dose oxytocin use. This is for labor stimulation, but again, if you made the chart for actual induction, it would be similar. And there's a whole variety of permutations about this. And again, it's based on recognizing that the dose of oxytocin is related to its pharmacokinetics. Overall, when you again utilize oxytocin, most would not have rates that would exceed 40 MUs per minute. So again, as you have these various increments as shown here, most would stop at this level, because going up higher to say 50 milliunits per minute also increases the risk for another complication of induction, and that is hyponatremia. So if you look at the risk, with low-dose regimens with less frequent dose increases, there appears to be in the data longer labors than high-dose regimens. However, there's less tachysystole associated with associated fetal heart rate changes. If you look at high-dose regimens, with more frequent dose increases, the labors are shorter, but there's more tachysystole with associated fetal heart rate changes, but less frequent chorioamnionitis and less frequent cesarean delivery for dystocia. Here's data from a large randomized clinical trial of low versus high dose oxytocin for induction and augmentation of labor. It included 1,300 patients roughly. 800 were having the oxytocin for induction, about 500 for augmentation. Caregivers were masked as to which oxytocin dose was used on individual patients, so this is a very nicely controlled trial. In the induction category, roughly a third or higher in both groups had cervical ripening, but the difference was not statistically significant. And in the augmentation category, however, about 8% of low dose and about 17% of high dose of the high dose group had cervical ripening, and that was statistically significant. About half of both induction groups had premature rupture of the membranes. And if you look at the data, particularly in the induction category, you can see that doing the high dose induction basically reduced the time to delivery by almost 2 hours without a statistically difference in the cesarean delivery rate, but again, a suggestion that it was lower. And the number of failed inductions were not different. In the augmentation category, here there's only about maybe an hour difference in terms of the time to delivery, and there was no statistically significant difference really between the risk of a cesarean delivery, though there's a suggestion that the high dose did increase that risk. This is another randomized trial looking at 4 labor induction methods. Here, almost 500 women were randomized to use of cervical Foley alone, misoprostol alone, and then combining the Foley catheter with either misoprostol or oxytocin. When they looked at the various characteristics of the 4 groups entering the trial, they were similar. And when they sort of took cesarean delivery out of the analysis and adjusted for parity, the cervical Foley and misoprostol group was twice as likely to deliver before the single agent group, but there was a reasonable similarity between the cervical Foley and oxytocin group as well. And here shows the graph, and you look at the bottom 2, the red is the most favorable, where again you see the number of patients who are undelivered was substantially less than the blue and green lines. The orange, which is the cervical Foley and oxytocin, although somewhat longer times or percentage of patients in terms of delivery, again, reasonably similar to the misoprostol and cervical Foley group. What about induction versus expectant management with term ruptured membranes? And this is data from a Cochrane database of about 3 years ago, where they reviewed 12 trials involving about 6,800 women. And again, looked at the induction with either of these agents. When they looked at the comparison, there appeared to be no difference in risk of cesarean delivery. However, the risk of chorioamnionitis and endometritis was substantially lower in the induction groups versus the expectant case groups. And the risk of a baby being admitted to the NICU also was substantially lower in the induction category as opposed to the expectant management category. So term ruptured membranes, rather than wait for labor, it appears to be more advantageous to both mother and fetus to actually move ahead with labor induction. So in conclusion, I've reviewed with you the multiple indications and contraindications to induction and stimulation of labor. I pointed out that it's important that we carefully assess the patient relative to starting induction to be sure that we've addressed the risk and benefits of the various approaches, obviously share that information with the patient before instituting whatever approach you decide seems to be the best. Balloon devices such as the Foley and prostaglandins certainly are frequently used for cervical ripening, and they all have their benefits as well as their risks. Oxytocin use is certainly relatively standard for induction. However, if the labor is progressing, it oftentimes can be supplemented with amniotomy. And certainly the risks of induction include, among others, infection, fetal heart rate abnormalities, prolongation of labor, failure, and ultimately even cesarean delivery.